All right, it seems like our attendance has stabilized, so we'll go ahead and get things started. Welcome, everyone, and thank you for joining us for this Bird Bites seminar. As a first note of housekeeping, this session is being recorded. Again, I'd like to welcome you. My name is Emily Slade, and I direct the Bird Corps here at the University of Kentucky Center for Clinical and Translational Science. I am thrilled today to introduce our speaker, Dr. Lindsay Hammerslag, who's an assistant professor in the Department of Biostatistics at the University of Kentucky College of Public Health. Her work bridges behavioral neuroscience, health services research, and public health informatics with a focus on improving outcomes for individuals with substance use disorder. Dr. Hammerslag leads statewide data infrastructure projects that support public health decision-making in Kentucky, including the development of interactive dashboards and data capture tools for opioid response initiatives that she'll be telling us about today. She's a co-investigator on several NIH-funded studies and a steering committee member for the State University Partnership Learning Network, advocating for cross-agency data collaborations that inform equitable, evidence-based care and public health interventions. So right before I turn things over, I'll ask you all to please hold your questions till the end. We'll have plenty of time for questions. Unless you have a clarifying question along the way, then feel free to drop that in the chat, which I'll monitor. With all that being said, I'm pleased to turn things over to Dr. Hammerslag.
Thank you so much. All right, I'm going to share my screen. Hello, everyone. If you attend the BioEpi lecture series, this talk might seem a little familiar, but for those of you who don't know me or haven't spoken to before, I'm Lindsay Hammerslag, and I've been working on the RADOR, Rapid Actionable Data in Kentucky project for the past couple of years. I'm going to share a little bit about what we've done on that project and some of our collaborations. So just to ground us as we start, we all know that there have been quite a lot of overdoses across the country, in Kentucky specifically. But what you might not have heard, depending on how much you pay attention to this, is that the rates have been dropping over the past few years. We've seen steady declines since the peak in 2021. This is some data that our team pulled together from Kentucky specifically. So things have been getting a lot better, and there's a lot of work left to do, but it really helps us to understand that the efforts that we've been taking have been effective, it seems, or something is changing within the environment. And that's that understanding something, what is changing in the environment that's helping with this problem is part of what we're trying to do with RADOR Kentucky. So this tool, we hoped to create a comprehensive source of information about the opioid epidemic to understand not just death data, but other factors that might influence deaths by ingesting data from multiple state agencies. We use advanced algorithms and automation to provide quick access to summaries and analysis. So as the data comes in, it gets computed automatically, really reducing the time between the data being collected and it being available to users. And it provides comprehensive and actionable data for opioid overdose prevention and control. So to give you a sense of the data that we're getting from our state partners, to give you a sense of how the system works, first I'll show you the basic idea is that we take our data from our state partners, we bring it together in the RADOR KY system by ingesting it into what we call a common data model, a way of making these very different data sources all compatible with our graphing tools. And then we produce the graphs of that common data model data and provide it to our stakeholders. Some of it is made publicly available with the idea of supporting actionable insights for targeted planning. Our data sources include emergency medical services data, Casper data. Casper is the all scheduled electronic reporting records. It's basically any scheduled prescription medications given out in the state. We get Medicaid claims data and enrollment data, which is very helpful for understanding how people are doing at the individual level. We get to understand their medical history as well as their prescription medication information and their encounters with medical services. We get death certificate records from police. We can obtain drug seizure data. So that gives us insight into the toxicity of the drug supply, another thing that might be impacting the fatality of overdose events. We get inpatient and outpatient discharge records. We collect data from various efforts to support recovery services and reduce death from overdose. So core program data, naloxone distribution data. We can even, for our modeling, use information about where people are being released back into the community after having been incarcerated. So all of these things we ingest, we bring them together, and we're able to use it to get a complete picture of what's going on. And that complete picture is very important because, yes, we are able to measure overdose deaths, and we can see that, year over year, they went up into 2021, they went back down again. But if we're just looking at the overdose deaths alone, we don't get a sense of what's causing changes. Um, they're a lagging indicator, so they can only tell us what's already happened. We have to look upstream in order to get a sense of what we're doing, what we could do better. We call that actionable data, things that we can take action with. And so that's where we look upstream for modifiable risk factors, like are people who are having an overdose being supplied with naloxone. That's where we look at our naloxone data. Are people who are known to have a history of opioid use disorder getting access to treatment? All of these things give us a better sense of how we're serving the community to reduce overdose deaths. So it's a really long way of saying that RADAR tries to give us a sense of not just what's happening and who's dying, but as we see things get better or as we're making our plans, what can we do next? What's working and how do we move forward? All right. So some of the measures that we have that focus on modifiable risk factors include risky prescribing, medication for opioid use disorder, non-fatal overdose, naloxone dispensing. So any of these we could look at as a factor that would be related to our overdose death rate. If we see fewer people getting what we call a risky prescribing event, so like a high dose of an opioid analgesic, or if we see more people who are getting medicated for opioid use disorder, who are being given evidence-based practice treatment with buprenorphine or methadone, these things we would expect to have downstream impacts on our overdose death rate. So I'm going to quickly walk through some trends in one measure in our RADAR KY data. This data is available to you all at radarky.uky.edu. I'll be focusing primarily on publicly available data, although I will go into some that you would require a login to access. I'll let you know if I'm not showing publicly available data. So I mentioned buprenorphine and methadone treatment, evidence-based treatments for opioid use disorder. These medications are very consistently shown to reduce the rate of death and reduce the rate of harms related to opioid use disorder, including hospitalizations and infections. They're very effective, very, very valuable medications, but not everyone who needs them is getting access to them. And so one of our features on our dashboard is that we have these tabs that focus on an important aspect of uh, helping to mitigate harms from opioid use disorder, such as treatment utilization. So this is our MOUD utilization tab. And here we give people a quick glimpse of how things are going on a monthly scale over the past couple of years. And we also give them a glimpse of how things are going on the geographic scale, just looking at the most recent month of data. This image hasn't been updated in a couple of months, but we would have more recent available data now, more recent data available now. But the idea here is that if I'm a policymaker or if I'm working for the state and I want to understand, I've got people who have opioid use disorder in my community. Out of those with opioid use disorder, what percentage are getting access to these life-saving medications? So on a statewide scale, it's about 50%. If I were to look, Eastern Kentucky seems to have better rates of access to treatment compared to some other areas of Kentucky. That could be a sampling issue, though, because we're only looking at people with a diagnosis. You have to always take things in context, but it gives me a glimpse into what's going on. We'll look a little bit closer at that. So here we have an annual graph of the percentage of Medicaid enrollees who have a diagnosis, who have received any medication for opioid use disorder. Um, so we can see that treatment rates over the past few years have increased. We didn't really see that in our initial glimpse when we were focusing on just the past couple of years. But now that we're kind of zooming out, we can see that increase over time, rising from around 35% of people with a diagnosis, so people we know need these medications, up to, in 2017, up to 59% in 2024. Um, we can look at it on this geographic scale. And I mentioned before, it seems like there's good access to treatment among those with a diagnosis in Eastern Kentucky. And we can also look at this ranked. So one thing that we discovered as we were meeting with our colleagues on the advisory board is that there are a lot of different perspectives that people bring when they come to use our tools. Sometimes they're very interested in understanding the big picture, but sometimes they're really interested in their own county. So perhaps I'm a resident of a specific county and I want to know how I rank, or I want to look at a set of specific counties and pay attention to that. So let's go ahead and go to the live system and take a look at. So if you were to go to the Radar system now, you would get to this live view of the dashboard landing page. So here's the overdose death data. We've talked about that. That's our lagging indicator. I'm really interested in treatment with medications for opioid use disorder. So here's the most recent version of that data I was showing you in my talk. So now, instead of showing you that static image from October, this is our data from July of 2025. This is because this is Medicaid data, it tends to have about a 6-month lag or more as it takes time for claims to get adjudicated. Um, but let's say that I am a member of Bourbon County, and I see that uh, in this talk back in October, Bourbon was not doing great. Then we could go back and highlight that county and see how they're doing right now. See if they've risen from seventh to, and they've gone up just a little bit. So if I remember Bourbon County, I could check in on this website regularly and see how I was doing compared to my peers. I could also say, well, here's Fayette. Fayette's not doing great at all. And they're ranked out of 120, 99th highest in terms of medication access. So Bourbon's doing quite good when you look at it from that perspective. So that's the kind of thing that we designed this for, to be able to, as a community member, keep an eye on how things are doing comparatively. It can help policy makers kind of be spurred to take action as well. Um, One thing that I like about this system is that our data does not just come from one source. I mentioned before all of our different data partners. So that Medicaid data that we receive captures only claims among Medicaid enrollees, and we limit it to those with an opioid use disorder. That can be harder to use when you're trying to think about all residents within a county, especially in the context of uh, people who are not getting adequate contact with medical providers. They're not going to get a diagnosis in the first place. They're going to fall out the denominator. Like, we've got a lot to think about there. And so it's nice to have a second view. This Casper data, that all schedule prescription electronic records, they let us zoom out from just Medicaid enrollees and look at all residents in the county. And so here's what that data looked like last year with all residents in our county and the rate of access to buprenorphine. So on an individual level, let's go ahead and change our measure to look at that here. And we can see in our advanced dashboard. This one has updating paused at the moment, so we're not going to have too much more recent data, but we can look at the map. and we can zoom in on a specific month here. So I think this is going to be pretty close to what you see before. This data is from October of 2025. So on a per resident basis, not worrying about whether or not they have a specific diagnosis or anything, we see pretty good penetration here of medications for opioid use disorder. Unfortunately, we don't know the prevalence. We don't have that measure in RADOR just yet. And so we're still missing a key piece to put this in context, but it's still a useful way to look at and think about things. All right. So we've already looked at this data. So now, one thing that our system deals with and that our team has gotten very good at is establishing trust with the data owners and our partners and making sure that anything that we share is appropriate to be shared. So if you've worked with data before, you're used to seeing things that are described as suppressed. That's our way of referring to something not meeting uh, the rules set forth to protect the privacy of individuals. And in this case, that means that this is annual data at a county level. These counties with these dotted uh, symbols had 5 or fewer deaths. So we're not going to show you the exact number because we don't want to like let's say it was only 1 death in the county, then you would know that that was your family member. We don't want to have the risk that you can identify things. And so here is how we show that. It's just suppressed. Can make it kind of hard though when you're dealing with rarer events like deaths to think about things. So this is at the annual level. Let's go back to our live dashboard and go to our death data. Right. So this is 2025 death data. Here's that 2024 death data you were just looking at. If we were to try to look at this on the quarterly or even the monthly level, most of the data is either suppressed or it's simply not there because there's a zero. Sorry, it's either suppressed or there were no deaths at all. Um, and so that makes it really, really rough to be able to work with. Um, our team has created a way of zooming out to these regional blockings. So there's a few different ways that regions are defined in the state of Kentucky. One that's particularly useful is these area development districts. Zooming out on the geographic scale or zooming out on the time scale are two ways to have fewer suppressed values and be able to do more with the data. So this is area development district, and this is something that is not yet publicly available. But with this, we can kind of think about and walk through the data to tell a story. So looking at area development districts throughout the years, we're going to frame it with that annual data that you've seen a few times now, where we had that increase in 2020 and 2021, the fall in 2022. So here's what data looked like across these area development districts in 2017, and we're just going to move forward in time now. So as time goes forward, we can kind of look at the relative trends, and we can see that some of these areas remained high relative to their neighbors, even as things were falling. But some of the areas that had really high levels back in 2017 relative to other parts of the state have had quite a substantial decrease. So we can see that maybe some areas in eastern Kentucky have not fallen as much as these areas in northern Kentucky. And Kentucky River Area Development District is one that I wanted to highlight, where it had relatively low rates in 2017 and relatively high rates in 2024. And if you were to compare it to the statewide death rate, the statewide rate in blue here, where we have that fall that you've already seen. In orange, we have the Kentucky River ADD. We see that that spike in 2020 and 2021 was particularly acute for this region, and the drop off has simply not been as strong as the drop off was for our statewide data. So that tells me that for Kentucky River ADD, perhaps something is not being done that needs to be done. And it might be useful for them to think about what's happening in the rest of the state, what they could do better. Okay, so I'm going to take a step back from that story now and talk more about just the development of the system. So the Radar Kentucky system has benefited from having a relatively large team working on it. There's a lot of members here at University of Kentucky, but also from a lot of community support and a lot of community feedback. We use something called user-informed design to help ensure that everything that we're doing is useful for those that would be using the data and that we understand what they actually need, not just what they're asking us for, but also what they are trying to do and what might make their lives easier. So our priorities as we were developing the system were to create something that was sustainable. We did this by using open source tools like Python, JavaScript, something called Leaflet, D3, which is a visualization package within JavaScript, MariaDB, and Bootstrap. So this gives us a way to stand up our database, to stand up our visualizations, the front end of our website, and some of the logic within our website. We wanted to make sure that our work is generalizable. And so we use something called a common data model to make sure that our system could rapidly accommodate new measures and be repurposed for other projects. Basically, all of our data is captured at the timescale level, so a month, a quarter, a year, in long format, along with the region that the data pertains to, and then the summarized, like the aggregated data for that region. If you were to go to our website and just pull up a random, let's say this bar graph, and we'll just look at statewide data for right now, you could kind of get a flavor for what this, actually, we'll include Fayette, for what this common data model looks like on the back end. We'll zoom in just a little bit for y'all. So when we download our data, you can see that different regions each have one row of data for each time interval. So here we are looking at annual data. So we have data by year for all of the state and for Fayette and our observations. So that common data model is really, really powerful, even though it's so simple, because it means that everything that we build does not care about the topic that we're working with. Pretty much anything on the Radar site can be very easily repurposed for another disease type or another subject, because as long as we've got enough, we call it metadata information about what we're working with, we can just change a few things and import the data. User friendliness was very important to us. Um, some of these tools, Python, JavaScript, they're more, um, there's a high barrier to entry for using them at times. We have full stack developers that have undergone computer science training and are much more tech centric than maybe a lot of us might be if our training is in epidemiology or biostatistics. But the level of expertise they have and the level of control they have over the data lets us really customize the system. So we can tightly control the user experience and look for ways to make things simpler or more intuitive based on the feedback that we get from our community partners. And then that feedback from our community partners has been so important. Our team has found a lot of occasions to engage with the partners and integrate their feedback. So we always talk about user-centered design as working through things as a loop. So we have our users, in this case, people involved in public health or in managing opioid use disorder in the community, a lot of our data owners, so representatives from the Cabinet for Health and Family Services, that kind of thing. We involve them at the start. We talk to them about what they need, what we're trying to do. And then as we're designing, we keep checking back in with them to see if something is useful or if we're on the right path, so that if something is working, we can make it better and more tailored to what they need. But if something isn't working, we can fail early and find a different approach. Um, so I'll give you an overview of how we've engaged with our partners. So we've gone through a lot of phases on this project. We were in the prototype phase for a while, undergoing partner testing before we did our first public release. And then we continued improving upon the Radar system. Now, if you were to go to our website, you would see that we've got our latest release always has the date up at the top because we've had quite a lot of releases at this point. And we have gotten feedback from our community partners by initially doing those structured interviews, but then we've had every 6 months a check-in with our advisory group to get really formal feedback on the state of things in the big picture. And then we do demonstrations like this, and we've had a lot of talks. Most recently, we were at the RX Summit in Nashville, where we're able to get unstructured feedback from the public. We also work directly with our partners and walk them through features just to see how things are going. All right. So I've shown you this website a few times already. I just wanted to highlight a few things that I think are particularly important design decisions that we made. I mentioned before that we have this landing page where we have tabs that are focused on topics. So these topics include a mix of lagging indicators, things like overdose death, as well as more upstream factors like non-fatal overdoses, which put someone at a high risk of having a subsequent fatal overdose, or access to and retention on medication for opioid use disorder. So these these topics were chosen by our subject matter experts that we work with. So Michelle Lofwall, Trish Freeman, Sharon Walsh, on our community engagement team. They were able to guide us through what they thought were important factors that anybody would want to be focused on to get a comprehensive picture of things. The very design of this page was informed by our advisory group. When we first created the system, it was a very uh, complex system. It was basically this was the first thing that you would see when you arrive there. And then we would have all of our different measures available in a dropdown. And at our advisory board, we were asked to make more useful summaries. And so that's where this page came from. We've got our data presented at an annual scale, and for data that is less heavily suppressed or that updates more quickly, like our non-fatal overdose data, we're able to show that at the most recent monthly data observation scale. We show a glimpse of trends over recent months for drug overdose deaths, which is again a very heavily suppressed measure. We show this at the quarterly scale, whereas for our non-fatal overdoses, we're able to show them the last couple of years of data with monthly bins, which is just a little bit more useful. We provide ranking information and a little bit of information on how the measure was calculated and how it might be used by someone, just to help ground that information, make sure that it is um, being couched appropriately and that they're given enough context to use it. Everything on here responds to clicks. So if I were to go on the map and choose to focus on Jefferson County, I would then have Jefferson highlighted on my county rankings. I would have it appear on my graph. And if I were to go to the advanced dashboard, I would keep that focus on Jefferson County as I moved into the next page, which can be very useful. We learned pretty early on that there's going to be people who are looking at things as a big picture and are more interested in the whole state, but there's going to be a lot of users that are interested in their individual county and just focusing on that story. And so we wanted to facilitate that. Um, let's see. One more thing. I'm going to focus on this non-fatal overdose measure now because this data does not have suppression rules. per our agreement with the K-beams, the data provider, and it has a really unique feature of coming to us so quickly that we're able to update our measures often within just a couple of weeks of the end of a month. So right now in mid-April, I guess it's coming up on the end of April, but we've got our March data in already, and we were able to use that March data to make predictions. So here we have predicted values for April and for May. Right now, this non-fatal overdose data is the only data set that we are making predictions on. At some point in the future, we may expand this to other data sets. I think the informatics team is still finalizing their methods here, but these predictions are generated using quite a lot of information. So some of those data sources I talked about, like the drug seizure data that looks at the toxicity of the drug supply, or the inmate releases, things like that can be really useful for understanding the risk that a community is facing in the months ahead. We can also look at seasonal trends. So generally, our overdoses tend to peak in the summer on a year-over-year basis. So our machine learning models have an understanding of these seasonal trends. We feed in information about other measures like treatment rates and that kind of thing. And we also feed in information about trends in adjacent counties. So all of that information goes together to help generate these models. And if you want to learn more about that, I would encourage you to reach out to my colleague Daniel Harris or Svetla Slavova. They have really good information about what we do here. And I think I saw Aaron Mullen was on the call. He's very skilled with the machine learning underlying the system. I think the only other thing, and I feel like we're still finding our way here, is our dashboard is built to accommodate many different measures. On the advanced dashboard view, someone could look through different measures. So let's say they are first looking at everybody in Medicaid who's receiving medication for treatment of opioid use disorder. They can then switch over to this measure looking at Casper data. I think that we have some work to do still to get this just where we want it, but it's useful to be able to give them different ways to look at a problem depending on their specific perspective and what they need to know. And there are some default settings I wanted to highlight. For those of you who do data visualization, there are a few themes that came up as we were working on this. Because this data is live and responsive, we found that it can be a little bit rough once too many variables are added at once. And so we set some logic that if too many cities are added at one or counties are added at once to look useful on the bar graph, that we would reset the bar graph. On the maps and the bar graphs, we move over to the annual scale instead of the monthly scale, again, to make it more interpretable. So even if they're looking at monthly data on the line graph, we presume that as they transition from the line graph to the bar graph, they're likely not interested in keeping that level of, I mean, if they wanted to continue looking at things on the monthly level, they'd stay on a line graph. So we help them by changing that setting for them as they go. Even if someone is looking at count data on a bar graph, when they move over to the map, we move them back over to rate data to encourage appropriate interpretation of the data. They can look at the count data if they want, but we are trying to help anybody who's using our website be discouraged from misinterpreting population effects when they really want to be looking at rate effects. So those are some of our default settings that I'm particularly happy with how they've turned out. And I think that you could use them in any visualization that you're putting together. So I will wrap things up by talking about some of our partner projects. So I mentioned earlier that the basic way that this radar system works is that we take data from our state partners and we turn it into visualizations and things that are useful for planning. as we were building everything, we learned from some of our partners that they really needed support with getting the data in the first place. There were a lot of opportunities and there's a lot of need for improving the data collection process. Um, and so we found ways to support them in obtaining that data and then sharing their data. We've also found that some of our partners have needed tools for um, like hosting their own websites and developing more formal outcome assessment plans. So we've been finding ways to support them as we go here. Um, and so two ongoing partnerships have developed so far. Uh, and I think there's another one that um, I'm not sure if we're allowed to talk about yet. So I'll focus on the two that I'm involved in. So these are my two partnerships are with the Kentucky Overdose Response Effort and the Kentucky Opioid Abatement Advisory Commission. And for each of these, we were supporting them throughout the process to improve their data collection in the first place, improve their dissemination of data to their employees and to the community, and to help them with outcome assessment and with mandated reporting. So the Kentucky Overdose Response Effort is a federally funded initiative, and they have reporting requirements through SAMHSA that we've been able to support as we've built their system. So um, with CORE, this ended up being a very mutually beneficial relationship because we actually have a pretty big gap in the kinds of data that is available to look at opioid use disorder. We have these things that are administratively captured, death data, anything that involves billing and health claims, those are fine. For naloxone, we were able to develop measures related to um, uh, based on our partners like administrative records drug seizure data, but we don't have things on recovery housing, peer support, referral to treatment. These are pieces of data that are getting captured. CORE, the Kentucky Overdose Response Effort, they're funding those activities. They just don't have a way, well, they did not have a way to capture the data quickly enough and with enough fidelity to make it suitable for ingestion into our system. And on the national level, these are just things that people generally have not had access to. And so we developed this partnership to help address gaps in the data that's available to us by creating a new pipeline of information about recovery and treatment services while also working to reduce administrative burdens on CORE and the programs that they fund. I think that this is really one of our main goals for this project was finding a way to reduce the pain associated with data collection. This organization had been collecting data from think it was more than 100 agencies or programs through monthly spreadsheets. And so they would try to harmonize them and get them together. And every single month, it was taking them hours and hours to do that data ingestion, to clean things up, to get the data that they needed. And it led to long delays in their ability to do anything with the information. And so we worked with them to develop a plan, and we actually obtained funding for this. So we were able to do this for our partners without cost to develop, launch, and administer a website that would allow us to get the data pieces that SAMHSA, the Substance Abuse and Mental Health Services Administration, needed to receive from CORE for their grants mandated reporting, and also support the agencies that were collecting data, more on that in a second, and create useful data for things like Radar Kentucky, groups that are interested in creating a more comprehensive view of services for opioid use disorder. We wanted to be able to adapt to teams with various levels of technical expertise and different workflows, and we wanted to be able to share our work with other agencies that are administering state opioid response funding. And so we interviewed agencies and determined that there were some large programs that needed very specific features, like being able to bulk upload data and kind of work with the medical records that they were already keeping and reduce the amount of times that anyone had to do double data entry or retype anything. Whereas small programs, some of these programs were collecting records on sheets of paper and had no way of kind of keeping track of things for the same client over time. They just had no ability to do this at all. And so they needed us to support them with a basic system where they could log their data and keep track of it. And so we built a couple of different distinct tools for those different workflow needs, including a bulk uploader tool and online record management. And so we were able to help CORE by taking their previous workflow of sending in spreadsheets and manually fixing them up to having their programs that they were collecting data on, enter all of that data into the CORE system in the form of online forms and automatically validated bulk uploads, and then send that back to CORE. It was a really fun project. So it went live on October 1st of 2024, and it's now in the hands of my DBHDID contract team. So it's being administered by the state contracts that were existing before we came around. Um, it's just become part of their workflow, part of their system. Um, this is out of date now. This is more like 50,000 unique clients and more than 200,000 treatment recovery or quick response visits. We've had really great feedback. We actually ended up partnering with CORE to build out additional tools in the past few months as SAMHSA changed some of the reporting requirements, and we've been able to support them there. So it's been really, really gratifying and fun to work with them on this. And at the end of the day, we now have very highly structured, carefully double-checked data at the individual level, including information about how many visits each individual has, that's suitable for use in our Radar system and will give us new insight into the receipt of some more informal treatment activities like peer support and recovery housing that we've really never been able to capture before. We also have a partnership with the Kentucky Opioid Abatement Advisory Commission that's been going quite well. We developed a way for them to capture, they call it local reporting data on the funds that they allocated to, that the opioid settlement funding gave to individual jurisdictions, so counties and cities. We've supported them with helping those counties and cities report on what they've done with the funding or what they haven't done with the funding. We're now turning all of that data that we captured into a dashboard that should be going live on July 1st or shortly after July 1st, where people will be able to look at their community and see how funds are being used locally and what's being done with opioid settlement funds. All right, I'm going to wrap it up here. If you'd like to learn more, we have a YouTube channel. There's one video up right now, and we'll be recording more soon. And this is an image of our team from kind of the kickoff of the project. The team's grown and evolved since then, and there's always changes happening. But it's very fun to be part of this team, and I appreciate the chance to have presented.
Thank you very much, Dr. Hammerslag. So if any folks have questions, please feel free to leave them in the chat or just come off mute and ask away.
I have a question for Lindsay. Um, I This is absolutely fascinating and incredibly impressive, and I am so intrigued with how your team did this. And I'm sure there are other teams across the nation that would like to replicate this and leverage data like this, both in their state or in their area. What are some practical considerations that teams who want to develop this kind of, not only just the data merge, but also the presentations, are there any that you would say are a must? And part two, what are other, like, where should we be fostering and cultivating the resources to get where you guys are at now?
Those are really good questions. So I will say the original grant for this was funded by NIDA. It was awarded to Svetla Slavova and Jeff Talbert. Those are our PIs. And Svetla and Jeff always had a plan to disseminate the tools that we developed here to other teams. And I know that that's something our team has been working on. And so Jeff Talbert ended up leaving the University of Kentucky and is out in University of Augusta Medical College in Georgia. And we'll be standing up an iteration of this system in the months ahead. I mentioned before that this particular system requires quite a lot of investment in developers. I think there are smaller scale ways to do things like this. It just depends on what an organization's working with. So I think groups should maybe take time, let their employees have time and freedom to explore some of the dashboarding tools out there. Um, all of us as University of Kentucky employees have free access to Power BI. If you haven't used Power BI yet through Microsoft Office 365, I highly recommend you give that a try and just learn what you can already do with what you've got. And I think once you start playing with data, it can give you a sense for what you want to do next and what you might be able to share out and make useful for people. And I'm sure I've missed part of your question.
No, that was fantastic, and I appreciate you really highlighting that there's already another iteration happening in another state. Do you guys anticipate that has there been expressions of interest from other institutions or states on this?
There
Or you love
has.
it?
I don't know how much I'm allowed to share. I guess it's okay to share that Dr. Slavova Svetla has currently a contract where we're building out some systems to support the Rural Health Transformation Project. So where our system's gearing up and our team has been expanding, and we decided to take a step away from the hyper focus on opioid use disorder, which is it's a lot of us are subject, like that's our thing. And so a lot of us are very comfortable in that area. But the more we presented, the more everyone kept asking us if they could just have the tool for other things. And we realized how generalizable it is. And so that's what our team is working on now is kind of moving beyond specific focus and thinking about how do we work with subject matters and experts in different fields, get the information that we need to present their measure data with high fidelity, you know, acknowledging enough of the limitations, understanding what's going on there, making it digestible, and kind of replicating the system.
Thank you. Any other questions for Dr. Hammerslag? All right. Well, thank you again for this excellent talk. Really appreciate it. I will turn things over now to Sarah Robbins, our fantastic bird program manager, who will share a little bit about what's coming up soon for Bird Bites.
Thank you again to Lindsay. I've put her Dr. Hammerslog's email into the chat. So if you have any further questions or want to connect with her and the Radar team, highly recommend doing that. They are a fantastic team, and we're happy that she was able to share that information with us. Also, I want to say thank you to everyone who has participated, is continuing to participate in Bird Bites. This is the last one of our 2025-2026 academic semester. We could not have done it without you all and your feedback as well. So if you have any recommended speakers or topics that you would like to see presented at Bird Bites, please email me or please email bird@uky.edu, and we'll happy to bring in presenters as well. But this is the last one of the semester, so look for further notifications and announcements of our next seminar series iterations in 26-27 via email from the CCTS or through CCTS social media such as Facebook, X, Instagram, and now LinkedIn. So thank you all, everyone. Have a wonderful Monday, and we look forward to seeing you around September with our September 2026 kickoff. So that's all I have for you all. Emily, back to you.
That's all. Thanks, everyone. Have a great day.